Pharmacy Friends, a podcast dedicated to bringing industry experts to the same virtual table to talk about what is happening in pharmacy today, what is coming in the future, and most importantly, what it means to you. Millions of Americans are diagnosed with type 2 diabetes, a serious and expensive health condition. Type 2 diabetes can lead to other serious health issues such as heart disease, stroke, blindness, kidney failure, and more. So how can we prevent this dangerous and costly chronic condition? Stick around for today's episode where we talk about all things diabetes and the key to improving health and reducing costs. Moderating today's podcast is Vice President and Medical Director, Dr. Marcy Shadroff. And joining Dr. Shadroff is Barb Korn, Vice President of Physician and Clinical Operations, and Dr. Arpita Gupta, endocrinologist expert and Magellan Rx physician clinical reviewer. Let's get into it.
Hi, pharmacy friends. I'm Dr. Marcy Shadroff. I'm the Vice President of Medical Affairs at Magellan Rx Management. I'm a board-certified internist by training, and I'm excited to be here today with Barb Korn and Dr. Arpita Gupta. Barb, can you tell us a little bit about yourself and your role at Magellan Rx?
Hello, I'm excited to be with you today. I'm the Vice President of Clinical Operations. I'm an RN and have a variety of experiences ranging from the hospital setting to various roles in managed care.
Thanks, Barb. Dr. Gupta, can you tell us about yourself and your role at Magellan Rx Management?
Thank you, Dr. Chadroff. I am an adult endocrinologist and I have been in clinical practice for more than 10 years. I am a physician clinical reviewer with Magellan Rx and I have been with Magellan for the last 2 years.
Excellent. Thank you both. Today, we are going to focus our discussion on the prevention of prediabetes and type 2 diabetes. This issue of prevention of both prediabetes and type 2 diabetes has been a national focus led by the Centers for Disease Control and Prevention over the last 12 years. In 2010, the CDC established the National Diabetes Prevention Program, otherwise known as the National DPP, which is a partnership of public and private organizations that are working toward the same goal of preventing or delaying the onset of prediabetes and type 2 diabetes through evidence-based, cost-effective interventions and lifestyle modifications. Before we discuss the National DPP in more detail, let's learn more about the incidence and diagnosis of prediabetes and type 2 diabetes. Dr. Gupta, what is the incidence of prediabetes and type 2 diabetes?
So diabetes is a global health crisis, and it has reached epidemic proportions in many populations. Here in the United States, 37 million people have diabetes, and this is 11% of the population. 1 in 5 don't even know they have it. The prevalence of type 2 diabetes is highest among Native Americans at 14%, followed by Hispanic Americans, non-Hispanic Black, and Asian Americans, with the lowest prevalence among non-Hispanic white Americans at 7.5%. The numbers are even more staggering for prediabetes, with 96 million adults having prediabetes, which is over a third of the adult US population. And 8 in 10 of these people don't know they have it. In 65 years or older, almost 50% have prediabetes. Diabetes is the 7th leading cause of death in the United States and accounts for medical costs and lost work and wages to the amount of $327 billion yearly. In the last 20 years, the number of adults diagnosed with diabetes has more than doubled as the American population has aged and become more overweight and obese.
Thank you, Dr. Gupta. How is prediabetes and type 2 diabetes diagnosed?
So diabetes is diagnosed when a person presents with the classical symptoms suggestive of diabetes, including thirst, polyuria, weight loss, blurred vision, and is found to have a random non-fasting glucose of 200 or higher. In a person without symptoms, the diagnosis is established with a fasting glucose of 126 or higher, a 2-hour glucose tolerance test value of 200 or higher, or an A1C value of 6.5% or higher. If one test is abnormal, then it should be repeated. If two tests are abnormal, then no additional testing is needed. If two different tests are discordant, then the test that is suggestive of diabetes should be repeated. For prediabetes, the cutoffs are lower. So for a fasting glucose between 100 and 125, on the glucose tolerance test between 140 and 199, and on the A1C 5.7 to 6.5.
Thank you for that overview, Dr. Gupta. Who should be screened for prediabetes and type 2 diabetes mellitus?
So the CDC suggests screening individuals 45 years or older that have risk factors that include being overweight, first-degree relative with diabetes, high-risk ethnic group, history of gestational diabetes, or having a sedentary lifestyle.
Could you elaborate on the risk factors that can lead to diabetes?
Absolutely. So family history is one of the most important risk factors for developing diabetes. So individuals who have a first-degree relative with diabetes have a 2 to 3 times higher risk of developing diabetes. This risk goes up to 5 to 6 times if both maternal and paternal history is present for diabetes. Hispanics, non-Hispanic Black, and Asian Americans are at higher risk than non-Hispanic white individuals. In addition to biological risk factors like BMI, waist circumference, blood pressure, there are socioeconomic, neighborhood, psychosocial, behavioral factors that play a role in this ethnic disparity. Other risk factors include obesity and an abnormal fat distribution in the central or abdominal area measured by waist circumference or waist to hip ratio. Physical inactivity, even if you don't gain weight, appears to increase the risk for diabetes. Quantity and quality of sleep, with short sleep less than 5 to 6 hours or long sleep more than 8 to 9 hours, is also associated with an increased risk. Sleep apnea is another factor. Dietary consumption of red meat, processed meat, sugar-sweetened beverages increases the risk, whereas consumption of a diet high in fruits, vegetables, nuts, whole grains, olive oil has a reduced risk. Cigarette smoking, as well as secondhand smoke exposure, does increase the risk for diabetes, and this risk is higher with higher number of cigarettes smoked per day and a longer pack year history. There are some medications also associated with diabetes, and these include glucocorticoids, statins for cholesterol, niacin, thiazide, diuretics, beta blockers, antiretrovirals, antipsychotics, immune checkpoint inhibitors, and immunosuppressants. And most of these medicines work by increasing insulin resistance, and some of them also decrease insulin production. Last but not the least, environmental exposures to arsenic, bisphenol in plastics, organophosphate, and then mineral deficiencies, including selenium, chromium, vitamin D deficiencies, have also been shown to have an association with diabetes.
Thank you, Dr. Gupta. And I'm sure that many people may have more than one risk factor, and this could actually elevate their risk even further.
That is right.
We've heard about metabolic syndrome. What does that entail, and how does it relate to prediabetes and or to type 2 diabetes? And how is metabolic syndrome connected to lifestyle issues?
Metabolic syndrome is a group of risk factors that raises risk for diabetes and cardiovascular disease. It is diagnosed when 3 out of the following traits are present, and these traits are abdominal obesity with a waist circumference more than 40 inches in men and 35 in women, triglyceride level of 150 or higher, or if someone is on treatment for it, a low HDL less than 40 in men and less than 50 in females, blood pressure higher than 130 by 85, or if someone is on treatment for high blood pressure, fasting glucose more than 100, or if someone is on treatment for blood pressure. So it entails glucose, blood pressure, HDL, triglycerides, and abdominal obesity. So metabolic syndrome has become increasingly prevalent, with the NHANES 2011 to 2016 database showing 34% participants meeting criteria. Individuals with obesity and metabolic syndrome had a 10-fold increased risk for diabetes and a 2-fold increased risk for cardiovascular disease compared to normal weight people without metabolic syndrome. In addition to diabetes and cardiovascular disease, metabolic syndrome is also associated with fatty liver, polycystic ovarian disease, chronic kidney disease, sleep apnea, gout, cholangiocarcinoma, hepatocellular carcinoma, and even cognitive decline and dementia. So aggressive lifestyle modification that focuses on weight reduction, increasing physical activity is the key in managing metabolic syndrome. Mediterranean diet, DASH diet, that is dietary approaches to stop hypertension, consuming foods with low glycemic index and high fiber can help treat metabolic syndrome. Exercise recommendation is a daily minimum of 30 minutes of moderate intensity exercise at least 5 days of the week.
And Dr. Gupta, what is the risk of progression to diabetes once prediabetes is diagnosed?
There is a strong continuous association between A1C and subsequent diabetes. The relative risk of developing diabetes is 20 times higher with an A1C of 6 compared with an A1C of 5. 5-year risk of developing diabetes is 10% at an A1C of 5.5, 25% at an A1C of 6, and as high as 50% for an A1C of 6.5.
Dr. Gupta, it is well known that patients with type 2 diabetes may develop complications such as retinopathy, which is loss of vision, nephropathy, which is kidney disease, neuropathy, which is loss of sensation, and vascular complications, which are problems with blood vessels in the legs leading to amputation. Could you tell us if there have been any studies that show that patients with longstanding prediabetes who do not progress to diabetes can develop similar complications?
Absolutely. It has been shown in the Framingham Heart Study that for every 1% increase in hemoglobin A1C, the relative odds for cardiovascular disease increase by 1.39. In the DPP trial, participants who had prediabetes but did not go on to develop full-blown diabetes had an 8% evidence of diabetic retinopathy. Prevalence of CKD among adults with prediabetes was 10%.
Let's talk about special groups that we are noticing an alarming trend of rising cases of prediabetes and type 2 diabetes in. What about our pediatric population, Dr. Gupta?
Metabolic syndrome, prediabetes, and type 2 diabetes is definitely on the rise in children and adolescents. Approximately 1/3 of children and adolescents in the United States are either overweight or obese. The overall prevalence of prediabetes in youth, 12 to 18 years of age, was close to 20%, 1 in 5. And the prevalence is even higher at 1 in 4, 25% among those who have obesity, and in males more than females. The incidence of type 2 diabetes in children aged 10 to 19 years was 37 per 100,000 in non-Hispanic Black, 20 per 100,000 in Hispanic, compared to 4.5 per 100,000 children in the non-Hispanic white youth.
These numbers are concerning. What is the reason for the increase in the incidence of diabetes and prediabetes in this younger population?
The association between obesity and type 2 diabetes is stronger in youth than it is in adults. Nearly 80% of youth who have diabetes have obesity. Children have an estimated 20% risk of developing diabetes by late adulthood, with one parent affected by diabetes. And this risk rises to 30% if both parents are affected. Metabolic programming during prenatal exposure, maternal undernutrition, or gestational diabetes promotes obesity and insulin resistance and increases the risk for type 2 diabetes. Puberty increases insulin resistance. And so most cases of childhood type 2 diabetes occurs after the onset of puberty, which is the time for physiological insulin resistance.
And who should be screened for diabetes and prediabetes in this younger population?
All children should be assessed for the risk factors for type 2 diabetes, which is obesity, family history, high risk ethnic group at every routine well child visit. Children who are overweight or obese and have one or more of the risk factors should go on to have the screening with either an A1C or a fasting blood glucose. And again, the risk factors are a first or a second degree relative with diabetes, a high risk ethnic group with a maternal diabetes or gestational diabetes, signs of insulin resistance, which could be PCOS, acanthosis nigricans, history of being small for gestational age, and screening should begin either at puberty or at the age of 10, whichever is earlier.
And what guidance is given for managing diabetes and prediabetes in this age group, Dr. Gupta?
One needs to be very aggressive in this age group to avoid decline in beta cell function over time. And management should focus on weight loss and lifestyle intervention. Weight loss surgery in severely obese has been shown to be beneficial. Role of medications in prediabetes to prevent development of diabetes, full-blown diabetes, is uncertain. There is available data from a few trials that suggest treatment with metformin can improve markers for insulin sensitivity and reduce BMI. However, these improvements are modest, and there is no evidence that metformin alters long-term risks for developing prediabetes or diabetes.
What about gestational diabetes? How can we identify and target this population? And what is the importance of aggressive management in this patient group?
Prevalence of gestational diabetes is approximately 6% in the United States. Universal screening is performed at 24 to 28 weeks of gestation using a two-step approach. First step is a 1 hour 50-gram glucose tolerance test. If the cutoff is equal to or greater than 135, if one fails it, then you go on to get a 3-hour 100-gram oral glucose tolerance test, the cutoff for which is fasting 95, 1 hour 180, then 155, and 140. So these cutoffs are much lower for diabetes in non-pregnant adults. Test is considered positive if 2 or more values are abnormal. Gestational diabetes in one pregnancy is a strong predictor for recurrence in a subsequent pregnancy, with frequency as high as 40%. And patients with gestational diabetes have a 10-fold higher risk of developing subsequent type 2 diabetes. And that is why long-term follow-up after delivery is very important. And this should be done with a standard glucose tolerance test with a 75-gram glucose load 1 to 3 months after delivery. Fasting glucose can also be used to screen for diabetes. However, A1C should not be used because it will be unreliable in the postpartum stage due to increased red cell turnover. Breastfeeding should be encouraged in all these females. Intensive lifestyle to lose weight back to the pre-pregnancy weight, metformin therapy can all reduce the risk for future diabetes by 50%.
Thank you, Dr. Gupta. Since patients with prediabetes and type 2 diabetes are at very high risk of severe complications that lead to morbidity and mortality, as well as high-cost medical care, the CDC's National DPP program is so important in helping patients to not only control their blood sugars, but also to prevent the severe complications. Barb, let's turn to you. Are there any reasons why the National DPP program is so important for patients with prediabetes and diabetes? Other reasons? than what I already described.
Currently, it's estimated there are over 37 million people in the US that have type 2 diabetes, and this is either diagnosed or undiagnosed. There's an additional 96 million adults, which is approximately 38% of the adult population, estimated to have prediabetes, which puts them at a high risk for developing, as Dr. Gupta was referencing above, type 2 diabetes in the absence of intervention. The cost of treating and managing diabetes is high and continues to grow. In 2017, the total cost associated with people diagnosed with diabetes in the US was $327 billion, which represents an increase of 26% over 5 years. Medical expenditures constituted $237 billion of that total, and reduced productivity was estimated at $90 billion. Approximately 1 in 4 healthcare dollars is spent on people diagnosed with diabetes, with most expenses tied to hospitalizations and medications to treat complications of the disease. The costs associated with diabetes have also accelerated in recent years. The economic cost of diabetes alone increased 26% from 2012 to 2017 due to the higher prevalence of the disease and increased cost of treatment. In addition, people with diabetes are also at a higher risk for other serious health problems, which again, we've talked about a little bit earlier, including heart attack, stroke, blindness, kidney failure, and amputation of toes, feet, or the legs.
Thank you, Barb. Can you highlight the clinical research that has been done by the Diabetes Prevention Program regarding prediabetes and diabetes prevention?
The Diabetes Prevention Program was a major multi-center clinical research study. The intervention involved a lifestyle change program, which focused on calorie reduction, increasing physical activity to at least 150 minutes per week. Results from the study showed that this structured lifestyle change program, in which participants achieved a weight loss of 5 to 7% of their body weight, which is 10 to 14 pounds for a person weighing about 200 pounds, reduced the risk of developing type 2 diabetes by 58% in adults at high risk for the disease. A 10-year follow-up study of the Diabetes Prevention Program outcome study showed that participants were still 1/3 less likely to develop type 2 diabetes a decade later than individuals who took a placebo. Those who did develop type 2 diabetes delayed the onset of the disease by about 4 years.
Thank you, Barb. And let's turn to more details about the National DPP program. Can you discuss the number of sites that the DPP has, eligibility for the program, and how the program works?
The CDC recognized diabetes prevention lifestyle change programs that can help people to prevent or delay type 2 diabetes and improve their overall health. In addition to these obvious health benefits, here are some other reasons that you might want to consider the diabetes prevention program. Again, as an organization, you will join thousands of others that have already offered this in-person program. And there's about 1,500 organizations that are in the registry, which is available online at the CDC website. The change programs have lifestyle coaches, and these are trained lifestyle coaches by the CDC. They're using a CDC-approved curriculum, and they have the knowledge and skills to effectively deliver the program. The lifestyle coaches' ability support participants, they provide guidance, they help the groups work together effectively, which is essential for a successful lifestyle change program. The curricula is, again, CDC recognized, and it must be backed by science and emphasize the overarching goals of preventing type 2 diabetes. They focus on making lasting lifestyle changes rather than simply completing the curriculum. You build up moderate changes in diet and physical activity that leads to the 5 to 7% weight loss in the first 6 months. Discuss strategies for self-monitoring of diet and physical activity, building participant self-efficacy and social support to maintain these lifestyle changes. And problem solving is included to overcome common weight loss challenges, physical activity challenges, healthy eating, things that people deal with every day, and how you can continue that momentum in the program. And there's a weigh-in that participants are subject to when they come to each of the classes, so that's recorded. And then there's also participant material that supports the program goals.
Thanks, Barb. And is there a cost to this program? And what is the time commitment for the patients who are enrolled in the program?
Most sites that offer this program charge a minimal fee. DPP is a year-long program. 16 weekly sessions and 6 monthly sessions, which are about 22 total sessions. The approximate direct delivery cost for administering the year-long program is around $500.
Thank you, Barb. Dr. Gupta, what is your approach as an endocrinologist in managing prediabetes and diabetes?
So, Dr. Chodroff, we need to adopt a patient-centered care approach when managing diabetes and prediabetes. The care needs to take into consideration individual patient comorbidities and prognoses, and needs to be respectful of a patient's needs and preferences. Care needs to be individualized, and one size does not fit all. Furthermore, social determinants of health must be addressed to improve health outcomes. So I start by assessing a patient's comorbidities and I judge their knowledge base. Then I teach them how to check their glucose using a glucometer or a continuous glucose sensor. Since diabetes is such a silent disease, it is very important to stay on top of it by proactively being aware of one's glucose trends through the day and its response to food.
Dr. Gupta, as patients start to see their blood sugars decrease over time with treatment, their hemoglobin A1C will also decrease. Is it possible to have a hemoglobin A1C that is too low?
So that is not the case in patients with prediabetes or diet-controlled diabetes. Fasting glucose less than 100 is considered normal. However, it has been shown that even with people having fasting glucose in the higher quintiles of the normal range are still at an increased risk for developing diabetes. For example, a fasting glucose of 95 to 99 still has a higher risk of developing diabetes compared to a fasting less than 85. And that is why lower is actually better. But one does need to be careful about a low A1C in patients who are on treatment for diabetes with insulin or sulfonylureas, because a low A1C in this group could be indicative of recurrent life-threatening hypoglycemia.
And a follow-up question, for patients in which their hemoglobin A1C level is in a low or normal range, does this mean that the patient is cured of their diabetes? Can diabetes be reversed or cured?
So there is no cure for diabetes, but it can go into remission. So it is possible to optimize diabetes control to a point that one can be diet controlled. However, the metabolic abnormality does not go away completely, and it can reverse with weight gain, poor lifestyle, physical inactivity, and an unhealthy diet.
The national DPP focuses on prevention, but there may be some patients who are not able to prevent or maintain their prediabetes or diabetes type 2 with the interventions that are part of the DPP. Dr. Gupta, what are the first-line pharmaceutical treatments that are prescribed for prediabetes and type 2 diabetes?
Metformin may prevent or delay the development of diabetes in subjects with impaired glucose tolerance. However, the long-term benefits and cost-effectiveness of early pharmacological treatment versus withholding this treatment until full-blown diabetes develops is unproven. So in the DPP trial, metformin plus lifestyle was associated with a 31% reduction in the risk of developing diabetes compared to placebo. However, metformin was less effective than intensive lifestyle modification. Metformin has been shown to be effective in males and females and all ethnic groups, but it is relatively ineffective in older patients and those who are less overweight. It is most effective in reducing the risk of diabetes in younger people with obesity, and particularly in women who have a history of gestational diabetes. One should remember, though, metformin is off-label for the prevention of diabetes.
Thank you, Dr. Gupta. Before we wrap up, it would be great to hear about the results of the national DPP thus far, particularly the cost savings of diabetes prevention. Barb, could you please share statistics about the results of the DPP program?
There's a variety of different sources that have tracked the national DPP results. So just to name a few, the CMS, which is the Centers for Medicare Office of the Actuarial, they looked at this on a Medicare beneficiary base and found that the National DPP Lifestyle Change Program would reduce or not increase net Medicare spending. For the commercially insured population, a return on investment in a group of commercially insured adults estimated an $8,015 increase in medical expenditures over a 3-year period for individuals with prediabetes who develop diabetes compared to individuals with prediabetes who do not develop diabetes. And that estimates a 3-year ROI, return on investment, of up to 42% in this population. The Institute for Clinical and Economic Review, known as ICER, they estimate savings of $1,146 per participant for in-person individual programs, $618 for online with human coaching, and that's with a 5-year horizon. There's multiple others. That's just to name a few, Dr. Chodroff.
Great. Thank you so much, Barb. And how can employers and health plans incorporate CDC recognized diabetes prevention lifestyle change programs into their covered benefits for their beneficiaries, members, employees who are at risk for prediabetes and type 2 diabetes so that there are both health benefits and financial benefits for all?
The National DPP Lifestyle Change Program allows payers to avoid the high cost of type 2 diabetes through delaying or preventing the onset of type 2 diabetes among covered individuals. The program provides direct financial benefits in the form of lower healthcare costs by preventing diabetes, and indirect financial benefits such as increased productivity and satisfaction among employees. One study of commercially insured adults found the $8,015 increase in medical expenditures, which was over a 3-year period of individuals with prediabetes who developed diabetes compared to the individuals with prediabetes who did not, and then versus $500, which is the cost on average of the National DPP program, which involves the Lifestyle Change Program, which is per participant per year. It may be difficult to quantify the economic benefits associated with the high levels of satisfaction of individuals participating in the National DPP Lifestyle Change Program. Beneficiaries and employees may be more likely to stay with a health plan or employer that offers quality and satisfactory programs.
Thanks, Barb. And one final question. If the audience would like to learn more about the CDC's National Diabetes Prevention Program, how can they obtain additional information and resources?
There's some great resources out there on the CDC site, and you can go there under the National DPP and search. They have multiple different choices of information you can find. There's a toolkit out there as well that you can look at, coveragetoolkit.org. You can also take the risk test that is available on the CDC site as well, and you can use that for your employees, you can use it for yourself. So there's great resources out there that will guide you for any questions you might have about the program. Plus, the listing of all the providers are out there as well, and you can search that by state.
Thanks for that information, Barb. We're at the end of our discussion for today. I would like to thank Barb Korn and Dr. Arpita Gupta for sharing their knowledge and expertise regarding prediabetes and type 2 diabetes, as well as the importance of the CDC's National Diabetes Prevention Program. Thank you both for being here with me today.
What a great conversation about diabetes and how we can prevent it to improve health and reduce costs. You can learn more about the Diabetes Prevention Program in the show notes, and until we chat again, make sure to subscribe and rate this podcast 5 stars. We'll talk soon.